Thank you for joining us for the appropriate use of telehealth for mobile crisis teams, presented by myself, David Eric Lopez, and Danielle Rahi. This presentation is presented by the California Department of Healthcare Services for the M-TAC project. A disclaimer, this presentation was prepared for the Medi-Cal Mobile Crisis Training and Technical Assistance Center, the M-TAC project, which is funded by the California Department of Healthcare Services and administered by the Center for Applied Research Solutions, CARS. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from DHCS, or the author's citation of the source is appreciated. Do not reproduce or distribute this presentation for a fee without specific written authorization from the M-TAC project. This presentation will be recorded and posted on our website. Conflict of interest disclosures, both myself and Danielle Raheb have certified that we have no relevant relationships with any commercial or nonprofit organizations that represent a conflict of interest. Mobile Crisis Services, the whole goal behind this project is that Mobile Crisis Services will provide rapid response to individual assessment and community-based stabilization to Medi-Cal members who are experiencing a behavioral health crisis. Mobile Crisis Services are designed to provide relief to members experiencing a behavioral health crisis, including through de-escalation and stabilization techniques. The goal is to reduce the immediate risk of danger and subsequent harm and avoid unnecessary emergency department care, psychiatric inpatient hospitalizations, and law enforcement involvement. And this is all found in the Behavioral Health Information Notice 23-025. With this whole benefit hopes to get us to a new direction for mobile crisis services. And the change and the goal is to get mobile crisis services so that the response is more resolution focused and works to provide relief to people in crisis in the community. We want to provide support to people in crisis where they are using the least restrictive means necessary. This new direction for mobile crisis services, the services should be person-centered, trauma-informed, equity-driven, provide brief intervention, de-escalation, and remain resolution-focused, working from a lens of the least restrictive interventions, be culturally responsive, linguistically appropriate, and accessible to everyone. And welcome. And today is being presented by myself, and I'll introduce my colleague, Danielle. If you want to say hello, Danielle.
Hi, everyone. Thank you for joining us today. My name is Danielle Ragib. I am a technical assistant specialist working alongside with David for the M-TAC project.
Yeah, and we're both from the Center of Applied Research Solutions, also known as CARS. And our agenda today is we're going to go over the definition of telehealth services. We're going to review the Behavioral Health Information Notice, BHIN 23-025, the requirements for appropriate use of telehealth for mobile crisis teams, California Telehealth Standards of Care, including Health Insurance, Portability, and Accountability Act, HIPAA, and confidentiality, telehealth and mobile crisis services, both the benefits and challenges of telehealth for mobile crisis teams. This training will provide an overview of the appropriate use of these telehealth for mobile crisis teams and the requirements outlined in the Medi-Cal Mobile Crisis Services Benefit Behavioral Health Information Notice, the BHIN 23-025. Participants will learn about telehealth technology options, standards of care in California, the benefits and challenges in telehealth use, and the next steps for implementing effective telehealth systems. Our learning objectives for today, we will review the BHIN 23-025 for telehealth services and mobile crisis team standards. Participants will review telehealth technology, options, and resources. You will learn about the standards of care in California for telehealth use. The training will provide an overview of HIPAA, and the confidentiality, participants will review benefits and challenges of telehealth in mobile crisis teams.
Thank you, David. What are telehealth services in California? Telehealth is not a distinct service, but an allowable mechanism to provide clinical services throughout the state. The Department of Healthcare Services coverage and reimbursement policies for services provided via telehealth modalities align with the California Telehealth Advancement Act of 2011 and the federal regulations. This comes from BHIN 23-018 on page 1, and this BHIN is released by the Department of Healthcare Services. State law defines telehealth as the mode of delivering healthcare services and state public health via information and communication technologies to facilitate the diagnosis, consultation, treatment, education, care management, and self-management of a patient's healthcare. Telehealth facilitates patient self-management and caregiver support for patients and includes synchronous interactions and asynchronous store and forward transfers. And this information is coming from the Business and Professions Code section of 2290.5A, sections A and 6. We have a link here for you as well if you'd like to review the BHIN 23-018, and there is also a link for the Business Professions Code. Telehealth and mobile crisis services. So we're going to talk a little bit about how telehealth is under this benefit, what telehealth looks like in terms of mobile crisis services for you as providers. So the BHIN 23025, which is the Medi-Cal Mobile Crisis Services benefit BHIN, says that mobile crisis teams shall meet the following standards. So at least 2 providers in table 1 in the BHIN, and we'll go over table 1, which is the table of qualified providers for the purpose of this benefit and this service. So at least 2 providers shall be available for the duration of the initial mobile crisis response. But Medi-Cal behavioral health delivery systems may allow one of the 2 required team members to participate via telehealth, which includes both synchronous, so audio only, and an example is telephone, and video interactions. So it could be telephone, it could be video, some sort of safe video streaming system that allows you to see each other. It could also just be the telephone, so voice. Mobile crisis teams may provide services in this manner, so meaning one person on site, the other person participating throughout the entire encounter via telehealth. If the behavioral health delivery system determines that such an arrangement is necessary because it would otherwise result in a big delay or marked delay in a mobile crisis team responding to the actual person in crisis. And the use of this arrangement, so the use of telehealth, would pose no safety concerns for the member or the single mobile crisis team. So meaning this is a safe enough scenario to go out with one person and the other person participating via telehealth. And so we want to make sure that if we're doing this because it is necessary, meaning if we weren't going out in a 2-person team physically, that when we go out with a 1-person team physically and 1 person participating throughout the entire encounter through telehealth, that it is safe for everyone involved. And so that is really important. And again, it's also very important to emphasize that that second person that's participating through telehealth, they must participate through the entire encounter. So they can't just be on for a few minutes or for just a portion of the encounter. They are required to participate throughout the entire encounter. The mobile crisis team providing the initial mobile crisis response shall include or have access to a licensed practitioner of the healing arts, so commonly known as a LPHA, as defined in the SUD treatment services or expanded SUD treatment services section of supplement 3 to attachment 3.1-A of the state plan, or a licensed mental health professional. So this could be like a licensed clinical social worker or a licensed marriage and family therapist or a licensed psychologist. They're different disciplines, as long as they qualify under the qualified team members or the qualified providers in table 1. You can also include a licensed physician, licensed psychologist, like I said, clinical counselor. You could also have a registered nurse, vocational nurse, or psychiatric technician, as long as they're licensed. So here's a couple examples of what team composition could look like. We get a lot of questions around team composition and who should go out, who shouldn't go out, who should be the lead, who shouldn't be the lead. This is really determined by you all. You all have to make the best choice of who's the best team to go out to this specific crisis, because every crisis is going to look different. Every person's need is different. And so if you have a peer support specialist who, has a very relevant background and experience, you might want to send that person, and they might want to take the lead. Just because they're not a clinician doesn't mean they don't have the capacity or the ability to lead the response and engage with the person in crisis. That is actually what we want to happen. We want the most appropriate team to be responding to the person in crisis. And so a couple examples of the mobile crisis team could consist of a licensed practitioner and a peer support specialist. So you have a two-person team going out, you have a licensed clinician, and you have a peer support specialist. And these are just examples. The compositions can look very different. There are a lot of providers on table one, and so it's just a mix of those, at least two. Two peer support specialists who have access to an LPHA via telehealth. So if you're sending out two peer support specialists, they just need to have access to a LPHA via telehealth when necessary. So if they need clinical support or anything like that, they need to be able to access that person at any point in time when they're out in the field. And that would telehealth, that person could participate via telehealth, either audio only or video interaction. It's the same kind of guidelines. Another kind of example of this is if you have one peer support specialist in the encounter via telehealth, so if you have a peer support specialist responding individually, and then the second person is a peer support specialist participating in the encounter via telehealth, then those two people still need to have access to a licensed person via telehealth at all times. So it will be like two people participating via telehealth. So this is just another scenario to give you, because these scenarios could come up all day, and we could, there are many different ways that we can play them out, but that is really what the guidelines are. So as long as they have access to somebody who is licensed at all times during the encounter. And again, it's really important to note, and we can't stress this enough, because this is a requirement of the BHIN in order to provide and be reimbursed for the service, is that second team member who is participating via telehealth, when you do that they participate and are engaged throughout the entire encounter. Telehealth and mobile crisis teams. And so there are several resources here that we have linked, and the links are available to you around telehealth services and the BHIN. And so the types of telehealth allowed for mobile crisis teams under this benefit are just synchronous care. And so there are other forms and other modes of telehealth, but for the purpose of this benefit, synchronous care is the only one that's allowable. And so telehealth allows you, again, to provide healthcare for a patient when you are not in the same location. Many of us probably see our doctors through telehealth, right? Because it's much more convenient now. And sometimes our copay is even cheaper. So it's just an option that we have now in healthcare services. And so synchronous care is the only option allowed under the benefit. And synchronous care is a live interaction between a provider and a patient. Visits may also include a caregiver. As appropriate, examples include video calls between a patient and a healthcare provider, audio calls when a video visit is not an option, and secure text messaging to answer patient questions. BHIN 23-025 defines synchronous care to include both synchronous audio only, so example, telephone, and video interactions. And this is the table 1 that I referenced a few times already, and this is directly from the BHIN. And this table gives you the list of qualified mobile crisis team members that qualify under the benefit. So your team composition could have any of these qualified providers on the team at any given time. And so it's quite a long list. And so I'm not going to go through it completely or anything like that, but you have it here. It's also in the BHIN. And so it's very important to know who is a qualified team member, because that obviously will impact the ability to reimburse for the service. And I'm going to hand it back to David.
Thank you, Danielle. So right now we're going to go over the Health Insurance Portability and Accountability Act, HIPAA, and the confidentiality in telehealth. So HIPAA and telehealth. The privacy rule protects all individual identifiable health information held or transmitted by a covered entity or its business associate in any format or media, whether electronic, paper, or oral. The privacy rule calls this information protected health information, also known as PHI. In telehealth and mobile crisis amongst the teams, it may be used to meet qualifying team requirements. So a two-person response, as Danielle was speaking to earlier, one could be on-site and one could be via telehealth. This could be on the phone or through a video conferencing system, whatever it may be that your team decides to use. Again, the important part to meet that two-person requirement, if one's on-site and one is on telehealth, is that they both must participate in that event throughout the duration of the time. So that's a very important thing to understand. Understanding that technology options, we want to make sure that they're safe and secure options. Healthcare providers should always use private locations to deliver telehealth and implement reasonable health insurance, Portability and Accountability Act safeguards, okay, for the PHI. The telehealth platform you use should meet the HIPAA requirements. The privacy rules safeguard standards is flexible and does not prescribe to any specific practices or actions as long as it adequately protects the privacy of PHI as appropriate to the circumstances from any intentional or unintentional use or disclosure in violation of the privacy rule listed under HHS Understanding Safeguards. Data security. The use of HIPAA compliant software. Providers need to use secure medical devices, provide telehealth services through a dependable, well-protected channels that will ensure data safety, identify the specific doorways that hackers might use for infiltration and close them off. We want to have secure endpoints. We want to secure each laptop, tablet, smartphone, and wearable device that transmits medical data. Implement telehealth care data encryption measures to protect them against theft. In addition, your office systems also need to have proper security systems protecting PHI 24/7. We want to build in privacy and security standards, induct telehealth in the privacy and security policies of the mobile crisis team, including training to the team about the use of telehealth software, provide them with telehealth-specific educational materials for maintaining security and abiding by these regulations. What information is protected by HIPAA? Well, individually identifiable health information, or PHI, is information including demographic data that relates to the individual's past, present, or future physical or mental health condition, the provision of healthcare to the individual, or the past, present, or future payment for the provision of healthcare to the individual, and that identifies the individual or for which there is a reasonable basis to believe it can be used to identify the individual. Individually identifiable health information includes many common identifiers, which include name, address, date of birth, social security number, etc. The privacy rule excludes from protected health information employment records that a covered entity maintains in its capacity as an employer and education and certain other records subject to or defined in the Family Educational Rights and Privacy Act 20 USC 1232G. Telehealth standards of care in California. Telehealth and Medi-Cal enrolled providers. Consent. Healthcare providers must inform the patient prior to the initial delivery of telehealth services about the use of telehealth and obtain verbal or written consent from the patient for the use of telehealth as an acceptable mode of delivering healthcare services. Providers also need to document when a patient consents to receive services via audio only prior to initial delivery of services. The consent shall be documented in the patient's medical file and be available to DHCS upon request. Providers are required to share additional information with members regarding right to in-person services, voluntary nature of consent, availability of transportation to access in-person services when other available resources have been reasonably exhausted, the limitations and risks of receiving services via telehealth when applicable, and the availability of translation services. Consent requirements may be found in the Business and Professions Code, Section 2290.5-B, and Welfare Institutions Code, Section 14132.725-D. Model patient consent language may be found on the DHCS website, and the link is listed below. Telehealth and Medi-Cal enrolled providers, provider requirements. The healthcare provider rendering Medi-Cal covered benefits or services provided via a telehealth modality must meet the requirements of the Business and Professions Code, Section 2290.5A3, or must be otherwise designated by the Department of Healthcare Services, DHCS, pursuant to the Welfare and Institutions Code 14132.725B2A. A licensed healthcare provider rendering Medi-Cal provided covered benefits or services via a telehealth modality must be licensed in California, enrolled as a Medi-Cal rendering provider or non-physician medical practitioner, NPN, and affiliated with an enrolled Medi-Cal provider group. The enrolled Medi-Cal provider group for which the healthcare provider renders services via telehealth must meet all Medi-Cal program enrollment requirements and must be located in California or a border community. For policy and billing information specific to FQHCs, RHCs, or IHS-MOA clinics, providers may refer to the Rural Healthcare Clinics and Federally Qualified Healthcare Centers and Indian Healthcare Services Memorandum of Agreement 638 clinic sections and the appropriate Part 2 manual that is linked below.
Thank you, David. And now we're going to talk a little bit about benefits and challenges for telehealth and mobile crisis services. The benefits of using telehealth and mobile crisis services, there are quite a few, right? One of the big ones was if we can't send out two providers because it would cause a marked delay, meaning we would get to the response of the person in crisis very late or not within the timeliness standard. That allows us to kind of get to the person quicker and provide the service quicker if it's safe to do so. So that is definitely one of the benefits. So being able to provide the mobile crisis service when only one team member is actually physically available to deploy from the team. It definitely assists in timely access to mobile crisis services. So if, sometimes there are very rural locations, it might be hard to get there. The weather could be playing a big role or impacting the ability to access someone, for two people to access that person. And so it just, it allows for increased accessibility. And again, that second person, we can't emphasize this enough just because it is a requirement of the BHIN and for the purpose of reimbursement is that second person must be actively participating and engaged during the entire duration of the service if they're participating via telehealth. This gives you another benefit is you have access to licensed providers for clinical consultation and support. And so if they can't physically be there, but they can be there via telehealth, that is definitely, increasing accessibility to these providers. We can provide community-based crisis resolution, leading to a reduction in unnecessary law enforcement involvement and unnecessary emergency department utilization. We increase access to consultation for special populations. So if we need to consult with someone who maybe is an expert with someone, the person in crisis, whatever they're going through, or if they have a certain diagnosis, maybe they have, IDD, a diagnosis of IDD, or some sort of developmental delay, and we need to consult with someone who's an expert in that. This really gives us increased access to those providers. We are able to provide the mobile crisis services to those who live in rural areas with limited access to care. So I spoke about this a little bit already is, sometimes the weather can play a role, geography, the land. And so if we can't get to them for whatever reasons, then we might be able to they can access us via telehealth. It's important to make the experience as positive as possible by providing as much information as you can from the start. And so, example, if the person that's physically there is able to say, hey, we're going to bring in another person. They're here to support and help. They're really here for you. And we're going to bring them up on a screen or through telephone, just kind of preparing them for the interaction that's about to happen. It may be something they've never done before. It may be something they've never experienced. And so it could be scary. Like, why is this person listening to me on the phone and asking me all these questions? I don't know them. And so making introductions, making sure that the provider on the participating via telehealth is making introductions and asking questions and being supportive as much as possible. So we want to make it a positive experience and make sure that the person in crisis is comfortable as well. And some of the challenges of using telehealth and mobile crisis services, as much as it's a benefit to be able to be more accessible to people living in parts of the county that may be more rural or just harder to access, it's also sometimes a connectivity issue, right? There could be a lack of cell signal coverage or low internet low internet bandwidth that make it hard to even connect or have a good connection, right? We've all been on those calls where person speaking and it's cutting in and out and you're not getting the clear picture and it's extremely frustrating. And so that is one of the challenges. So one of the things that we have made recommendations and other counties are able to do or have tried out before, or even first responders, is provide telehealth services utilizing mobile hotspots or satellite services to make sure that there is a secure connection that is strong enough to be able to provide the service so that we can hear and see when we need to appropriately. When using voice-only services, sometimes it's hard to observe any nonverbal cues, right? And that, that there are ways around that. You would consult with the person that's physically there afterwards. Did you notice any physical or verbal cues that I couldn't see because I'm just participating via phone? So that is one of the challenges as well. And in this field and working with people in crisis and responding to a crisis, it's important to look at how somebody is expressing through their nonverbal cues, right? They're expressing something that is communication. Um, there can be challenges with building rapport when a person is in crisis and participating via telehealth. But the more we front load them, the more information we give them, the more we ask about their comfort and what they might need, the more this might also aid that. So that is definitely a challenge, is building rapport with a person in crisis through telehealth is a little bit harder and more challenging. Voice only may not work for everyone in crisis. So, think about someone who might be in a paranoid state. That might not be the best mode of service for them to receive the service, because we don't know their state of mind. They might be in place where they think that this could add to their crisis. This could escalate their crisis. And so we always want to make sure that it's an appropriate use for the person in crisis. It's not something that is going to escalate or cause more harm. And some of the next steps for getting started with telehealth services as a mobile crisis team. Where do you go to get started? Consider connecting with local emergency service departments, such as fire or police departments, to ask about what technology they use, what's best for the county. They may also know areas of the county because they're responding to all parts of the county. They may have knowledge and experience in certain parts of the county where they already know there's limited cell coverage, limited internet service, and they can let you know that ahead of time. So definitely connect with your local emergency departments, service departments to access and gain that information, that knowledge. Know which internal county department you should go to for support with telehealth services. So who is the department that oversees the devices and the policies and all of these things around telehealth services? We should be connecting with them so that we have strong knowledge of how we provide telehealth services, what that looks like in all ways. So, what devices are we using? What service are we connecting to? All of those questions. You want to know your policies and procedures specific to your county around providing telehealth services. Yes, there are the requirements of the benefit, right? We talked about the standard of care in California when it comes to telehealth services, but you also need to know your specific county policies and procedures around providing services via telehealth. The California Telehealth Resource Center provides tools and resources for getting started with a telehealth program, including consultation services and online provider training and educational courses. And this is all free to anyone who would like to utilize this resource. And we have it linked here as well. Some of the commonly used devices for telehealth services are cell phones, tablets, iPads, laptops. internet hotspot devices, and satellite cell phones or cell service. Here are some additional resources, and everything here is linked for you so you have access to it. Additional resources for standards of care for telehealth services and providers. So in addition to, the standards of care in California, the telehealth requirement in the BHIN, and just telehealth here in general in California and those requirements, if you're a licensed or waivered provider who is overseen by a governing board, for example, licensed clinical social workers, licensed marriage family therapists, and others, we are overseen and governed by the Board of Behavioral Sciences. So there is a telehealth best practice guidance document there. So you also want to make sure that you're in alignment with, if you're working under a license, that you're in alignment with your governing board. The California Board of Psychology has a FAQ on telehealth as well. The DHCS also has a FAQ on telehealth, and the Medi-Cal and telehealth resource page on the DHCS website has some great information on providing telehealth resources. And again, the California Telehealth Resource Centers that provides the free educational courses for providers, as well as any consultation services as you get a telehealth program started. And then for peer support specialists, the Department of Healthcare Services actually has a peer support specialist FAQ. So very specific to what requirements you must meet as a peer support specialist and what are the standards for you as a peer support specialist providing services via telehealth. All right, in summary, from today's lesson or today's presentation, we have learned that telehealth services are allowable under the BHIN 23-2025 in specific circumstances. And the circumstance is when it is necessary to have the second provider participate via telehealth to provide timely and accessible services, and no danger would be presented to the person in crisis or the team. And that one provider who is remotely engaged must participate again throughout the entire encounter. When utilizing telehealth, providers may only provide synchronous care. So that is the requirement under the BHIN. They must be live, present, and fully engaged during the encounter, the entire encounter. Providers engaged through telehealth must be a fully qualified team member under the requirements described in BHIN 23-025. And again, that's Table 1. HIPAA rules protect all PHI information provided during a telehealth encounter, and all telehealth services must comply with HIPAA requirements. HIPAA requirements include ensuring that all software is HIPAA compliant and that all hardware has appropriate data protection measures in place. There are both benefits and drawbacks to engaging providers via telehealth. Telehealth can increase access to additional qualified team members, specialty providers, and extend benefit-eligible mobile crisis services in rural areas. Telehealth can also be limited by uneven cellular and internet bandwidth, the ability to observe and interpret nonverbal cues, and challenge the ability of mobile crisis responders to quickly build rapport with members. And this is just a quick reference page for you as well. Everything is linked so you have access to it. Thank you so much for joining us today. This information is all available to you as well in the PowerPoint, and all the links are available to you as well. And if you have any questions or concerns, please feel free to reach out to us at the M-TAC Center, TA Center, and we will get back to you. If you are interested in any sort of technical assistance service as well, you can access that on the website and request that service. Thank you so much for joining us, and wish you all a great day.